Assessment. My name is Alveen, another face for sure success. So today we will be learning about the respiratory system, but before we are beginning, I already mentioned some of the etiquette to my class. Please turn your cameras on. I will be asking lots of questions. Please stay focused and please raise your hands and try to answer me as much as possible. Ask me more and more questions. Okay, another thing, I really don't like when you are making the notes. You are not paying attention to my classes. The only way to grab the things, to learn the thing, is when you are fully present to the class, when you are not worried of making the lecture, making the notes. So once again, have your paper and pen ready, but write the heading, write the today's date on the left side, today's date, 4th of September, and today's respiratory 1. When I'm teaching you, just write down the headings. Assessment, Alveen is going to teach about assessment. Today we learned about tracheostomy. We learned about ventilators. Okay, only these 3 things should be on the pages, nothing else. And test yourself after the class. What I remember, okay, what I remember, then change the color of the pen, go to the presentation tab, read the respiratory 1 lectures, and then go through that what I needed to, what I forgot after 30 minutes of class, then write down those points. Okay, now let's begin with the respiratory lectures. Just give me a second. Okay, so today I'm going to finish the respiratory assessment and we will finish some diagnostic procedure. We will do respiratory drugs in tomorrow's class. Okay. Okay, so raise your hand. First of all, I'm not going in depth about in the anatomy and physiology. I hope everybody knows how we are breathing in, how we are breathing out. You know what is bronchioles, pharynx, larynx, trachea, lungs, right? How the gas exchange is happening. So please raise your hand and help me with this picture. Anybody wants to have a stage? Yes, Navdeep Kaur.
Yeah, anatomy is related to physical structure of the body and physiology is related to functioning of the body.
Yes.
And the respiratory system divided into 2 parts, upper respiratory tract and lower respiratory tract.
Yes.
In upper respiratory tract, we have oral cavity like mouth, nasal cavity, nostrils, nares, pharynx, larynx, and in lower respiratory tract, we have trachea, primary bronchiole, lungs, alveoli, bronchioles.
Very nice. Very good. So these are some of the anatomical names of the respiratory system. So when you are breathing in, the air goes through mouth or your nose. Why we have to breathe through nose? Because our air, when we are breathing in, get humidified. Okay, it get warm. So always breathe through your nose. You will notice when it is so cold in Canada. So what will happen if you will breathe through your mouth?
It will dry out.
It will dry. Okay, it will dry. So same thing, students. So when you are giving the oxygen and the patient is unconscious and if he's on oxygen mask, right? So why oxygen has property to dry out? Okay, so what do we usually do when somebody is on oxygen? Humidifier. And our body naturally has a humidifier. And which organ is it? Nose. Nasal hair. Okay. So for example, if somebody is allergic to cold environment, for example, asthma. Asthma is an allergic reaction which can happen due to many reasons, right? So let's suppose that the person is aggravated asthma in the cold weather. So what is the teaching? Please breathe in through your nose. Those are the things. Yes, Jessie, what is your question?
No, sorry, I didn't have any question. I
Okay.
just raised
All
it
right.
to answer
So
your
since you
question.
raise your hand, do you know what is voice box of our body?
Yeah. Larynx.
Because
Larynx.
no.
Everybody remember larynx. Now, another tip. So, as I told you that I don't like you to cram the things. Whenever you think there is any problem in larynx, what will be the sign and symptoms? Larynx is known as voice box. So, what is your guesses?
Hoarse voice.
Hoarseness of voice. So, for example, you are having strep throat. Throat means strep throat means streptococcus in your throat. When it goes to your larynx, you will have hoarseness of voice. When you have laryngitis, itis, inflammation of larynx, what will be the sign and symptoms? Hoarseness of voice. You won't be having hoarseness of voice for any other problem. Hoarseness will happen if the larynx is involved. And do you know how the voice is being created?
By vibration.
By vibration. How the vibration, I will show you in the next picture. So what is happening? So we have a throat here. We have, this is trachea, this one is esophagus, and this lining, which is dividing it, it has the larynx. Larynx is on the top. This red color is larynx. So whenever you are breathing out, right? So it will get vibrated. Okay. And you are starting producing your voice. I will be teaching you cancer of larynx today. Okay. When they, not the cancer of the larynx is the issue. The problem is laryngectomy, removal of larynx. So if you don't have larynx, will you be able to speak?
No.
Tell me.
No.
Never. No. Never.
No.
Right? So now I wanted to tell you because we will be learning today tracheostomy. What is tracheostomy? Opening in
The trachea.
Trachea.
trachea. Are we doing something in larynx? No.
No.
So do you think the patient can speak or no? They can speak. No, they can speak because they still have larynx. How? We will learn it in later class. How we are, because sometimes they ask the question, patient is having difficulty in speaking. Patient want to learn to speak with the tracheostomy. So we will learn how to teach them. But if the patient doesn't have larynx, then he can never restore his voice. Okay, this is the first thing. Now let's learn about the gas exchange. How the gas exchange, once you are breathing in the air, in and out, it goes to alveoli. How the gas exchange is happening as per the picture? Help me, Mandeep, Tanoa. Mandeep Kaur?
Right. Gas exchange occurs when we inhale, so the carbon dioxide goes in it, and when exhale, so the oxygen comes in, and
Yes.
the carbon dioxide goes out,
Yes.
and it's mixing with the capillaries of the blood.
Very good. Now, students, I wanted you to imagine, because this is another problem students have. Let's imagine there is a swelling over this part in the alveoli or the bronchiole. So how do you think it is affecting the air in and out? How it is affecting?
Because narrowing.
Because of narrowing, what happened?
Improper gas exchange, like they don't purify the gas, like our body do not get the proper oxygen.
It's
Yeah.
like
You
it
have
is
hard
Lack
time
of
breathing.
oxygenation.
It is
Okay.
really hard to inhale and exhale when there is
Yes.
a narrowing of the body, narrowing of the tubes, and it's gonna cause the hoarseness of the voice.
Hoarseness happens in lungs, alveoli.
Lungs, okay, not okay.
Who is producing hoarseness of voice?
Larynx.
The
Larynx.
larynx. Yeah.
Okay. So now another problem is, what happened is usually when we were learning the nursing in our schools, the common myth whenever I ask the students, whenever there is an inflammation, your answer is, ma'am, the patient is unable to inhale, right? Less oxygen is going, which is correct. But there is another problem. Less oxygen, less carbon dioxide is going out as well because of the tightness.
Yes.
That is another problem. So if there is an inflammation, less carbon dioxide is going out. So what happens in the lungs? Amount of carbon dioxide
Yes,
is
ma'am. Increased.
more.
Acidosis.
increased. Acidosis. Okay, very good. So very nice, students. Gas exchange. So first of all, I think I introduced myself. You probably are going to see my dog here, Halo. Sometimes she is very noisy. Hello, can you please give me the pen? Good. So I'm sorry for that one if she is being distracting me or you. Okay. All right. So let's get back to the topic. So what happens is when you're breathing in and breathing out, our alveoli are in direct touch with the capillaries, where the oxygen is going into the capillary and carbon dioxide is going out. If that is not happening, then gas exchange is improper. Now, let's suppose this is the swelling is one part. Another issue is, let's suppose there is a lot of fluid is collected in the alveoli. So is there any problem in the ventilation going in and going out?
Yes.
Is there any problem in going in when you're breathing in, breathing out? Is there any problem in breathing in, breathing out?
No. Yes.
No. Where is the
Yes.
problem?
Infection.
The problem is that perfusion,
Inside
the
the
capillary
perfusion.
oxygen is not going into the lungs and carbon dioxide is not going out of capillaries. That is the issue. Okay. Now, another thing I just wanted to tell you, students, whenever there is any problem of any respiratory system, the first thing you do is assessment. Okay. Inspection, palpation, percussion, and then auscultation. Now we are going to learn about the assessment. So write down the heading assessment, that's it. Okay, inspection, palpation, percussion, auscultation, head to toe, you are doing the same thing, except which organ? Which system?
GI.
GI system. Because what we do first after the inspection?
Auscultation.
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 Rest everyone, every system, we are doing inspection, palpation, percussion, and auscultation. Inspection, what do we do in inspection? Inspection we do with eye, with your eyes. So tell me, usually as soon as you have a patient who is having shortness of breath or something, what do you inspect? Let's me, right? So for example, I'm short of breath or something, what do you want to assess with your eyes?
Facial expressions. Your efforts.
My efforts, respiratory efforts. Yes.
And taking breath so fast.
Color of body.
Color of the body, very good. Color of the body, you can see it with an eye. Is the respiratory effort easy? Is the patient using abdomen or accessory muscles? Normally, we don't use any muscles. It's naturally happening, breathing in, breathing out. But in case, if the patient is using nasal flaring, it is a kind of muscle. Chest retraction, abdomen muscles are being sucked in, right? Then it means the breathing is not proper. Then we sometimes see barrel chest. Barrel chests in COPD patient, you can see this patient is COPD because of looking at his chest. Barrel, it looks like he's having some kind of barrel. It is so big. Check the wound, pacemaker, any subcutaneous port on the chest, etc. Another very confusing term, chest pain. Whenever I say chest pain, okay, most importantly, students, every time they think chest pain means myocardial infarction, but it is not like that. Okay, for example, let's imagine that I punched you on your chest and you have a wound and you are having pain. Where is the pain? Pain is on the chest. You are having chest pain. Does it mean that you're having myocardial infarction? No. So whenever you see the word chest pain, don't assume that he's going to have myocardial infarction. Okay, yes, chest pain with the left-sided chest pain, if it is generally happening, if he's having other sign of myocardial infarction, which is good. But do assess the whole situation. If there is a motor vehicle accident, patient is bleeding, his chest is open, he's having pain when he's breathing in, breathing out, he's having chest pain and there is a mosquito bite on his. So please have a look to the scenario. So now let's imagine I'm your patient and I'm having chest pain when I'm breathing in, during the breathing. So does it mean I am having the myocardial infarction or something related with lungs?
Something related with lungs.
Something related with lungs. What it can be? Any guess?
Pleural effusion.
Could be
Pleural
pneumonia.
effusion is one of them. Pleural effusion, yes, it can be.
Pneumonia.
Pneumonia, very commonly when we have any chest infection, okay? For example, pneumonia. Do you think all the patients are having chest pain when they're breathing in, breathing out? It is in
No.
the alveoli. No,
Not all, yes.
not all.
Tuberculosis.
Tuberculosis, have you heard about chest pain during breathing? Have you ever studied about? So student, what happens is pain happens because of something. You usually don't feel any pain. You don't have the pain receptors in the alveoli. That is why you won't be having the pain in pneumonia or cancer or something. What happens is the outer layer of the lungs. Do you know what is the outer layer of the lung is known as? Outer layer of the lung.
Is it parenchyma?
Pleura. Very good. Pleura.
Pleura.
So it is the name. Pleural cavity, pleura. Outer layer of the lungs is different. Cardiac system is different. Every organ, brain, cardiac system, your lungs have the outer layer, protective layer, which is, you can see it in the picture, blue colored. This is known as pleura. If this pleura is swollen, then because you will be having the, when you are breathing in, you are pressing this pleura cavity with your lungs and your skin. That friction is causing the pain. Are you getting me? And when you will auscultate, it is a typical auscultation. Typically, you will hear, because when the pleura is frictioning against your skin and your lungs, it is causing a special kind of noise. Do you know what we call it as? Pleural friction rub. Okay, pleural friction rub. Maybe you have heard this term, but now you can relate it here. Pleural means this is a pleura. Friction, it is friction with the lungs and between the skin, between your skin, and rub. When it is rubbing against, that noise is being created. So it is a stabbing chest pain When it is increases, patient is having the pain, but he is having too much pain when he coughs or when he is breathing in. Especially breathing in is making it more worse. It is causing, why it is happening? Because of the inflammation of the outer layer. Usually the pleural space, normally this one has the pleural fluid, little bit 10 ml of fluid, which is really good to help the lungs to glide on that. But in case if it has a lot of fluid in the pleural cavity, we call it as
Pleural fusion.
pleural effusion. And what is the treatment if there is too much fluid? Do you think the lungs will take it out? No. We are going to remove it with the needle or with the chest tube. Okay, but I'm talking about the inflammation of the pleural cavity, and we call it as pleurisy. Okay, we are not calling it as pleuritis or something. Pleuritis, we call it as pleurisy is the common word. And when they are rubbing together, again, it is known as pleuritic pain, pleuritic friction rub. And how it is happening, why there is a swelling? Because of the complication of the infection. It can be tuberculosis, can be pneumonia, but complication. Okay. And what is another very common happens for anybody who is having real problem with the with their immunity? For example, less immune people, children, or the adults with the old people, they are having the issue. And students, I just wanted to tell you how the pleural friction rub sounds like. I want everybody to put your hand over your ear. Everyone put your hand over your ear and scratch your hand. So the sound it is creating, it is a pleural friction rub kind of. So when you are frictioning, when you are rubbing your hand against your palm, that typical sound you can auscultate with the pleural friction rub. Okay. Do you have any question? Okay. So now when I am talking about the pleural friction rub, now let's move on to auscultation, because very important. In your NCLEX exam, you are going to get a lot of question. Patient is having crackle, patient is having pneumonia, patient is having stridor, he's having this kind of sound. What will you do? So you have it is very important to know the difference between the sounds. First of all, you should know how the normal sounds like here, like, okay, how can we auscultate the normal sound? To be honest, for your practicals, even if you forget the vesicular breath sound, bronchiovascular, bronchial sound, these are the normal sounds. But in case if you forget these words, it is not the end of the world. Because they are not asking you about the normal breath sound. The patient is having bronchial sound, vascular sound. They will be asking you, the patient is having crackles. You tell me what is happening. Okay. First of all, if you have the headphone, use your headphone. I'm going to play the sound so that you see how the normal breath sound sounds like. Okay. And please, everyone, mute yourself and try to use your headphone and let me know. Just give me a second. Can you hear? So this is a vesicular sound. Okay, so this one is a vesicular sound. Vesicular sound, as you can see, the inspiration and expiration. Please have a look. Please listen to it nicely and tell me which one is more, which one is less. Or they are equal. or they are equal? Vesicular, let me tell you, vesicular, you can remember. Expiratory, this one is little bit shorter as compared to it is longer and reduced breath sound than inspiration. E comes first, I comes longer, so E is shorter, I, inspiration is little bit longer. Now let's hear about the bronchiovascular sound, bronchial. These are equal. Got it? You don't need to remember if you are putting too much pressure to which one is shorter, which one is longer, no matter. I want you to understand and concentrate on the noise, on the voice, what it sounds like. There is absolutely no abnormal breath sound. It is very clear. The air is going in, air is going out. Okay. Now let's move on to other slides. Now we are going to differentiate it with the others, with the crackles, wheezing, bronchi. Crackles, I want you to, easy way to remember is, crackles. Just imagine any disease, if there, it is a kind of Rice Krispies. For example, you have a milkshake. Okay, and you are drinking it with the straw, but you are actually pushing the air into the milk and it is creating a bubbling noise. That one is crackles. And any time you have secretions in your lungs, you will hear the crackles. Can you name any of the diseases where you can imagine there is a fluid in the lungs?
Pulmonary edema.
Pulmonary edema.
Pulmonary edema. Pneumonia. Pneumonia, whenever there is bacterial infection, you have lots of phlegm coming through your lungs. That is having. Cystic fibrosis. Heart failure. The whole fluid is going back to your lungs and you are listening to crackles. So crackles mean what? Fluid is in the alveoli. Crackles, we sometimes call it as rails. And you can remember rail in the tail. Tail means the end part of the lungs. Which is the end part of the lungs? Alveoli. Then we are wheezing. There is another sound, wheezing. W for wheezing, W for whistling, whistle sound. Have you seen the flute? How the people are using the flute? So what we are blocking 2 or 3 holes and it is creating a musical noise. Same thing. What happens whenever there is in your bronchioles or whenever there is a swelling, whenever there is a blockage in this bronchioles due to inflammation, whenever the air is going in or going out, it is creating a musical noise. And the musical noise, that is the reason why it is creating a sound of wheezing. So wheezing is telling you that the airway is tight. Tight because of inflammation. Like asthma, COPD, airway obstruction. Then rhonchi usually happens in the bronchi. Sometimes if you have ever worked in ICU or have you ever seen any ICU patient, sometimes when the patient is on ventilator, it sounds like a snoring. It sounds like the secretions are here in the bronchioles. Those are rhonchi. Rhonchi means the secretions in the large vessels, large airway. And you can simply, what you can do is suction it. You can tell the patient to cough. Now let's hear out that how these sounds like. Wheezing, okay? Wheezing, once again, W for wheezing, W for vessel. Okay, now please pay attention. Is there any question? Wheezing, is it clear? Wheezing. Now let's move on to crackles. Once again, crackles or rales affect the tail alveoli. And what do you think it sounds like? Like a bubbly thing, right? Pay attention. Okay, are you able to differentiate between the whistling sound and this sound? Very good. Now let's move on to ronchi. Ronchi in the bronchi. Okay, see. You can actually hear it. See, if you will remember the normal sounds of the lungs, right? There was no secretions, nothing. It was all empty. It was going good. Crackles, you can see it is in the alveoli. When you will hear the alveoli sounds, like at the base of the lung, you will be hear the crackles, and wheezing is the tightening. Rales ronchi is always in the bronchi, in the larger airway, and you can see there is some fluid in that. You can hear it, auscultate it, and try to understand, try to relate that thing. See, the air is rushing these secretions. Can you see that? That is, just imagine yourself and try to concentrate with the sound again. Okay, now the most dangerous one is stridor. Okay, stridor sound, you can think of stridor. It is a kind of squeaky door. For example, if you're fond of horror movies, most of the horror movies have this scene that where there is a door on the attic and it is opening and closing, right? And it is make a very horror kind of squeaky door sound. That sound, we call it a stridor. It is representing there is an obstruction on the upper airway. For example, you will hear this sound when somebody is choking. And whenever you hear this stridor sound, what is the first step? Immediately maintain the ABC. For the crackles, we are going to give some. Which medications do you think we are going to give to the crackles?
Furosemide.
Furosemide, very good. Yes. Which medication you think you're going to give in wheezing?
Albuterol or salbutamol.
Albuterol, salbutamol, or steroids to decrease the inflammation. For the stridor, it can happen because of choking or because of extreme tightness of your upper airway. Airway is completely blocked, and that is a stridor. Immediately go and see the patient. He might need ventilator after that. So stridor is always your priority. So it is not always the choking. Sometimes it happens because when the upper airway is too much narrow after the wheezing. When wheezing is okay, inflammation is there. But when it is completely silent or when the stridor started happening, it is a danger. Okay, so this one is a stridor. These are the 4-5 names, student. It is not much. Whistling, crackles, stridor, and bronchi. Okay, I hope you will, like, in the future when I will be asking you, okay, tell me about the COPD, what is the expected auscultation? I hope you will be able to give me the answer. When we will be teaching and learning about pulmonary edema, I hope you will be able to answer me that, Alveen, I am expecting to have this sound. Any questions so far? Very good.
Yes, Miss.
Yes.
So for stridor constriction of the airways, we giving oxygen help in
We are giving
releasing
the
the
oxygen. If you're going to hear, if the oxygen is helping, yes. If you will check what will happen, how to decide we are giving to oxygen or not. We are checking the SpO2. We have to assess the patient. If it is very less, we do not waste the time. We do the tracheostomy or we ventilate the patient with endotracheal tube. Assessment is not only limited to auscultation. We have to see the other things. Okay.
Okay, so outside the SpO2, the oxygen, is there any other pharmacological agents that can be given to patients if the stridor it's
the pharmacology? Yes. We are going, for example, if it is happening, I am allergic to shrimps and to seafood, and somebody give me shrimp pasta or something, I will be having stridor. Which medication do you think I should have? EpiPen.
Epi.
Right? So we are going to cover the pharmacology. It depends what is the reason. If it is asthma, I'm going to give you the steroids. If it is allergy, I'm going to give you the EpiPen. If it is a choking, I'm going to give you the CPR or abdominal thirst. It depends. Okay, every situation is different. We will be doing some questions, and in fact, when you are dealing with the question, I will be teaching you the pharmacology. Wheezing can happen because of many reasons. Crackles can happen because of many reasons. What is the reason? For example, if it is a pneumonia, you will give the antibiotics, right? If the crackles is happening because of pulmonary edema, you will give the Lasix. Are you getting me? So it depends that what is causing it. Okay. Now, the last part of assessment, we discussed about the inspection, we discussed about auscultation is the main. Now let's talk about something with the touch. Okay, we call it as tactile firmness. So students, let's learn this term by doing this question. The nurse is performing a physical assessment on adult client. The nurse should assess the tactile firmness by what? Read the options. Try to have a guess. Very good. And any student who is little bit confused, anytime you lose when what it is, try guessing. Tactile. What is tactile? Just try a guess. Tactile means
Touch.
touch. And firmitas is vibration. So tell me, touching and vibration, which option it sounds like?
Third one.
Yes, the option number C. Tactile, firmitas. Okay. So now let's learn about the tactile firmitas. What happens is when you are touching the patient and you are sensing the vibration, how you are checking, for example, everybody will touch their chest. Now, when you are talking, you will see there is a vibration, especially when you say the word with N99. Everyone, mute yourself and say 99. Can you feel the vibration? Right? That vibration we want to see. Now, what is this vibration is telling you? Now, this is the question, what it is telling me. Now, let's imagine I have a jar, I have a bottle, okay? I have an empty bottle, I have an empty and the bottle with the water, okay? And I'm shaking it. Which one will vibrate, empty bottle or with the water?
Empty.
With the water.
Navdeep.
No.
So when there are two water bottles, there is one empty bottle and you are just, while shaking it. And
Sorry.
another is with the water. Which one
Yeah.
you feel the vibration?
With water.
With the water. The same thing, students. Normally, we are having very, very normal mucosa. Normal vibration, what you felt is the normal. When you feel too much vibration, it means too much secretion is in the patient's lungs. For example, whenever you get sick with pneumonia or something, okay? Or the patient, sometimes kids get so sick if you have a kid at home. You try to touch their chest when they are sick, when they are too much secretions, when they are having too much cough. You will feel the more vibration. More vibration means more secretions, he is sick. Less vibration means there is lots of air. There is no mucus. It is too much air. For example, in COPD, too much air. The air is not going out because of the swelling. Okay, that is what is tactile firmitas is telling you. Okay. Okay. Now, another thing is very important, students. We have three different terms, right? Oxygenation, ventilation, perfusion. Sometimes when we study respiratory system and we all think this is all related to respiratory system, they all mean the same, but actually no. Okay. First of all, let's talk about ventilation. Ventilation, a hint I want to give, ventilator is known for ventilation. So what do you think ventilation is?
In
What
and
does
out of
ventilation?
the air.
Ventilation means in and out of the air. When you're breathing in, breathing out, that is ventilation. Okay, that is why we call that machine is ventilator, not oxygenator. We don't call it as perfuser. We call it as ventilator. Air is coming in and going out. Okay. For example, when I choke, where is the problem? Ventilation, my ventilation will stop. It is telling you there is a problem in the airway. Where there is no problem in the ventilation, but alveoli is very much swollen, there is a pneumonia. Now, what is the problem? The capillaries will not get oxygen and the carbon dioxide is not going in and out. That is known as oxygenation. For example, in pneumonia, is there any problem in the ventilation, breathing in, breathing out? No. Where is the problem? Problem is in oxygenation. Now let's suppose I am doing, I'm shoveling the snow. I don't wear the gloves. My hands are so cold and they are blue. So what do you think if I will check the SpO2 oxygenation? So what does it tell you? What do you think is oxygenation is going to be normal, low or high?
Oh, low.
It will be low. Very good. Because what will happen with the cold? Constriction. My hands are very cold, vasoconstriction, and you will check my oxygenation, it is low. Does it mean that I have a problem in the lungs?
No.
No.
It is telling you I have a problem in perfusion, oxygen in the tissue. So these three things, these three terms are not same, students. When I say perfusion, I am telling you that how the oxygen is going to the organ. For example, whenever there is a respiratory issue, we check the mental status of the person. Why we are checking the mental status? Is the oxygen going to Alveen's brain? What I'm checking? Perfusion. Alveen's lung is good, oxygenation is good, ventilation is good, but perfusion is good or not? Perfusion means checking the oxygen, peripheral vascular disease, peripheral artery disease. When you will check the oxygen, it is very low. Does it mean they have a respiratory issue? Never. Right? So try to understand. So if you know these three terms are different, you will know. So it is not related to respiratory system, right? So that is. Now what you do normally, now we discussed about the auscultation. Now we will be covering what should we do if there is a compromise in ventilation, oxygen and perfusion. I will teach you about some of the treatments today. And we will discuss the problems tomorrow, because problems, as soon as I will be telling you, you will going to teach me. You are going to discuss with me that, Alveen, I'm going to give this medication. I'm going to do this thing with this patient. Okay. Now with the compromise and any compromise in the patient's ABC, what we normally do, either we give the medication or we give the respiratory support system. Okay. We are going to discuss the respiratory support system. So students, before I start the respiratory support system, I'm having for a little bit respiratory issues as well, little bit shortness of breath. So students, why don't we take a little 5 minutes break and we'll be back, and I will give you 15 minutes break later, okay? So 5-minute breaks to now, what is the time? 4:52, come around 5 p.m. It's Alberta time, or 7 p.m. At Ontario time, okay? I will see you all. Now let's get back to respiratory support system. So in the respiratory support system, what I'm talking about is oxygenation, oxygen. Okay. Normally, we know that whenever the doctor orders 4-liter oxygen, 2-liter of oxygen flow, right? Whatever this one, what does that actually mean? Okay, flow. Flow means how much liter per minute of gas is flowing from that cylinder. It can be 100% of oxygen, or it can be half oxygen, half you are inhaling from the air. Okay, it can be low flow or high flow. Low flow, for example, in the hospital, normally hospitals, we have oxygenator beside the bed. Have you seen it? Okay, everybody, I hope you must have seen the oxygenator on the bedside. Usually it is up to 15 liters. We consider it low flow. High flow is that if I need more oxygen than 15 liter, it is a high flow. Okay, I will give you the example. I will show you the picture. Another term we normally, maybe you have seen FiO2. Okay, not important for your exam, but I am teaching you as a nurses also in future. Have you heard the word FiO2? right? And the
Yes.
oxygen in the ventilator. Do you know what does it mean? FiO2. Usually anybody who has worked in ICU or who has seen the patient on ventilator, you must have seen FiO2 over the ventilator. FiO2 means that out of this liter per minute of gas, how much of that is oxygen? For example, when you all are breathing in and out, do you think you are inhaling whole oxygen? Only oxygen? No. How much oxygen is in the environment? Only 21%. So what is your FiO2? 21%. You are breathing in, breathing out, but FiO2 means how much in fraction of inspired oxygen you are inhaling. Sometimes there are diseases when your SpO2 is so low, you are giving the oxygen through oxygen mask, you're giving this and that. Sometimes we need 100% of FiO2. Whatever the gas she is inhaling, the patient is inhaling 100%. It depends on different machines. And there is another pressure. Another word, pressure, means sometimes we need to support the ventilation. Patient is not breathing on his own. I have to control how he breathes, how much pressure I have to put so that the gas is going into his lungs and getting out of his lungs. That is known as pressure. Okay, so these are the three terms we need to know. Now let's discuss about the oxygen devices, low flow and high flow, right? I hope everybody have seen oxygen mask, nasal cannula. What do you think oxygen mask is? Low flow or high flow?
Low flow.
Low flow. Yes, it is low flow. Okay, nasal cannula, face mask, face tent, etc. So what is the difference between low flow and high flow? Low flow means we are giving the stable FiO2. Means whatever is in the environment plus 2 or 3 liters or 10 liter or plus 15 liters on top of that. Low flow, patient is deciding that how much I am breathing in. For example, when you are giving the facial mask to the patient, okay, it is the patient who is breathing in, breathing out. You are not controlling it. If his SpO2, if he's breathing in respiratory rate is 20, he's breathing more oxygen. If his respiratory rate is only 10, he's breathing less oxygen. It is low flow. Okay, usually oxygenator beside your bed whenever you're using it, just think it is low flow, 0 to 10, 0 to 15 liters. And common example of low flow, simple mask, reservoir mask, non-rebreather mask, which is very important. Versus high flow, it gives you accurate amount of oxygen. So for example, if I need FiO2 of 60, 70, I need to very well control how much oxygen I need to send it to the patient's body. Then I use the high flow oxygen. And usually the delivery flow is at least 50 to 60 liter per minute. And maybe you are using ventilator, tracheostomy, nebulizer, aerosol mask. These are high flow because we are using the machine. Okay, example of the low flow ones are nasal cannula. Everybody knows how it looks like. Simple face mask, everybody knows how it looks like. Now let's talk about oximeter. In case if you hear oximeter, it is a high flow cannula. It is a kind of nasal cannula, but it is a fancy. This is how it looks like, low flow. Very important for your NCLEX exam is non-rebreather mask. Okay, non-rebreather mask. Let me show you the picture and what are the kind of questions it's coming in NCLEX exam. First of all, a non-rebreather mask looks like this. What do you mean by breathing? Rebreathing. What do you mean by rebreathing? For example, I want you to imagine you are wearing N95. You know, during, let's go back to the COVID-19 era when we were wearing the mask. When you're breathing out and you are breathing in your own breath, right, from the mask, we call it as rebreathing. Okay, that is known as rebreathing. Now this cannula, this oxygen mask, we call it as non-rebreather. So any hint what it is doing?
We breathe our own, what we exhale. The carbon dioxide goes in, I think so, in our reservoir bag, and we inhale oxygen again.
Okay, yes, you are correct, half correct. Okay, so what happened is we have expiratory valves here. When you are breathing in, you are breathing the oxygen coming through this oxygen line. Okay, and when you're breathing out, your whole oxygen will be going, or carbon dioxide will be going out from one valve, unidirectional, means one valve. Only the oxygen, only the carbon dioxide will go out. It won't let the outer air enter into the mask. Okay, so it is unidirectional. So that is why it is called as non-rebreather. You are not breathing your own breath. Last breath, it is gone out. Now, what is the difference than the other one? What is this reservoir means, right? This reservoir. So oxygen, this is known as oxygen reservoir. So what happened is, the question sometimes came in the NCLEX exam that, and this bag is not inflated. What will you do? Which is telling you a hint, giving you a hint that when you are giving this mask to the patient, this reservoir mask should be inflated like a balloon. How to make it inflated? This oxygen pipe, which is attached to the this oxidizer. Okay, when it is attached, this pipe is attached to this one, you are going to put it full, make it full up here. Too much oxygen. This one directly will go into this bag, and when the patient is breathing, he will be breathing through his bag. Only oxygen he's breathing. He's breathing in oxygen, and he's not rebreathing his own previous breath. It is going out through these valves. It will go out through these valves, and he's taking the breath from this one. So this one is not actually giving the oxygen to the patient. This one, you are turning it on full. In order to, your main goal is not that, if, for example, if you will turn this one, this is for example, my cursor is a ball, you are turning it on, it go up to 30 to 40. It doesn't mean you're giving the 40 liters to the patient. You are turning it up to inflate this balloon. Patient is inhaling through this balloon. And what is the most important question? That there is a new graduate nurse, and you are the registered nurse, and you are saying that she has given the non-rebreather mask to someone, and the balloon that inflate the reservoir is not inflated. What will you do? It is a negligence. First of all, it means that you don't know how it works. So what will you do? Immediately inflate the balloon. How you will inflate it? By turning the reservoir to highest. Are you getting me? Do you understand? Have you seen the reservoir, this non-rebreather mask?
Yes.
Sorry,
Yes.
Alveen, just want to clarify it. So what you're saying is when the oxygen goes to the bag, and then patient will adjust according to whatever liter he needs through the bag. We have
Yes.
nothing to do it. We'll just put it on the full if that's one of the options.
Yes. We are
Got it.
turning the flow to the highest.
Okay, we're not harming the patient or anything.
We are not
We're
harming
just-
the patient. We are not harming the patient at all. So
Thank
that is
you.
why the patient is inhaling according to his respiratory rate. And which diseases we usually give this reservoir? not diseases, when your SpO2 is very low, less than 70, usually, right? So for example, if it is 80s, 88, you start it. If it is early 90, 91, 92, you give the nasal cannula. If it is in 80s, you try doing the simple face mask. If it is even worse than that and the patient is breathing, do you want to intubate the patient who is breathing? No.
No.
What is a choice? Non-rebreather mask. This is the one we are using. Okay. So this one is non-rebreather mask. You should know how to inflate this balloon. And then high flow, where we will control, it is more than like 50, 20 to 50, 24 to 50, 21 to 100. It is up to 100% of oxygen flow liter we are going to give. Venturi mask or high flow nasal cannula. It is written high flow nasal cannula. Nebulizer is a high flow. This one, Venturi mask, look like a normal mask. But in case in real life, if you see very colorful things, okay, you will see these colorful things. These are Venturi mask. We are controlling how much percentage of the air we are going to give to the patient. Okay, so this is Venturi mask. It has the same thing as of oxygen. Okay, Venturi mask looks like this. Now let's talk about the pressure devices. What are the common things? First thing come to your mind when I'm talking about the devices which is putting the pressure to the patient's head?
Ventilator.
Ventilator. Okay. Before we reach to the ventilator, between the non-rebreather mask and ventilator, there is another medium option with the pressure. Yes.
Ventilator.
Non what?
Non-invasive ventilator.
Non-invasive ventilator. Can you name them?
CPAP
And BiPAP.
Very good. CPAP and BiPAP. Okay. CPAP and BiPAP. So CPAP and BiPAP, first of all, I should tell you how it looks like. It looks like this, nothing else. It looks like an oximeter. It is a machine. Do you know why we use this CPAP and BiPAP? Most the common disease we use this one.
Sleep apnea.
Sleep apnea. Very good. Sleep apnea. Okay. So what happened is CPAP, as the name indicates, CPAP means continuous positive airway pressure. This is a machine when it is continuously set on one pressure. This is how much amount of pressure I'm going to send the air into the patient. For example, it is 20 mmHg or whatever it is. So it is continuously giving, as the name indication, CPAP, continuous pressure. BiPAP means bi-level pressure. BiPAP means bi-level positive pressure. It is a little, this one is very cheap. Okay, because most of the people can afford CPAP. BiPAP is a little bit fancy, nothing else. The only thing is what two kind of pressure it is. Two different pressure setting. When the patient is inhaling, it is different pressure. When the patient is exhaling, it is different pressure. But it looks the same. Okay, so this is a difference between the CPAP and BiPAP. It looks like this machine. Now let's talk about the invasive ventilation. Invasive ventilation, when we are putting into patient's body to ventilate the patient. We will learn about endotracheal. Endotracheal inside the trachea. Where is the trachea? From endo means from the mouth to the trachea. Or we are talking about the tracheostomy, and we will learn about the ventilators in today's lecture. Okay. So endotracheal students, as the name indicate, endotracheal, through mouth, nose into the trachea. Okay. Why we are giving endotracheal or tracheostomy tube to which patients? Any guesses?
Unconscious patients.
Unconscious patient. Not unconscious men. There are many people who are in coma, who are unconscious, but they can breathe. Any person who can't breathe their own, your airway is not maintained, we need to put the ventilator into the patient, endotracheal. Okay, how do we know endotracheal tube is in place?
X-ray.
When there is bubbles, yeah. Hi.
With the help of X-ray. Endotracheal is, you are putting the tracheal tube over here. This blue is endotracheal tube. Okay. How, for example, I will ask you that let's suppose that the respiratory therapist, he put the endotracheal tube, and when you first auscultated, the breath sound is heard over the right side, but there is no breath sound in the left lungs. What it is telling you? After the ET tube, if it is only in right side. Huh?
It's not placed right.
Yes, it is displaced to the right side. Okay, it is displaced. So always make sure, verify the placement with the X-rays. And it is not the X-rays, you did that and that's all. X-rays and check the centimeter, how much centimeter. For example, it is 45 centimeter, always write it down. Okay, and next time it is 47 or next time it is 43. Right? So what is the first thing it tells you? Auscultate. And auscultate for what? Auscultate for equal breath sound. It should be given to the right. It should be equally to the left. And whenever there is a right, only on the right side, only on the left side, it is telling you that it is gone. It is displaced. So what will you do?
Reposition.
In Canada, we are not allowed to. We are going to tell the respiratory therapist.
We call
have
the
a separate
RTT.
degree. Okay, so they will do that. You will send the patient to the X-rays. Now let's talk about the tracheostomy, where we are covering the surgical hole to insert the tube directly into the tracheostomy in the trachea. Now the problem with the tracheostomy, there is no problem. It will be equally going. For example, in the tracheostomy, let me show you with this one. With the tracheostomy, it will be equally to both part. The air will be going to both part, both lungs, and right lung and left lung. Now the issue is, the number one issue with the tracheostomy is infection. Because it is directly in our mouth, our nose, our nasal hair, it prevents lots of infection, unfortunately. And another thing with the trachea, as I told you, normal humidifier of our body, nose, is bypassing. You will be more dehydrated, you will be more drowsy, you will be more dried out with the tracheostomy. Okay, always use the humidifier. And in case if we want to take out the secretions, always make sure you are going to you do the suctioning. Okay, make sure you are not doing the suctioning. I will teach you later. Not do it more than how many seconds?
10 seconds.
10 seconds. Okay. Now, students, I wanted to tell you another thing. I will show you one of the video. Okay. Let's say this is your tracheostomy. I have inserted, this one is tracheostomy. And again, just wait. This one is your larynx. Okay. Do you think the patient can speak? Yes or no?
Yes.
If the patient can speak. How he can speak? If it will vibrate. Have you seen that there is a cuff? Whenever there is a tracheostomy, there is a cuff, right? We insert in urinary tube, ET tube, tracheostomy tube, whatever the tube you are inserting it, we inflate the balloon. So when you are inflating the balloon, what will happen? It is pushing this lining. Okay, and do you think the air is going when the balloon is fully inflated? Do you think the air is going up? What do you
No.
think? No.
No.
Do you think if there is no air going up, do you think the larynx will be vibrating? Will it vibrate without air?
No.
No.
Can the patient speak? No.
No.
So what happens is, if the patient, he's having permanent tracheostomy, and if he wants to speak, what we will suggest them? Deflate the balloon when you are talking. When you will deflate it, the air will pass through the tube and it will vibrate it, and he can speak. Another thing I wanted to tell you is, when you will inflate the balloon, why we are inflating the balloon at first place?
For placement.
For the placement, so that it is not coming out. It is important.
Ensure
it is
the
important
placement.
to ensure the placement. Now, another thing is, when you are inflating the balloon, there is a chances of pressure ulcer to this lining, and it is putting the pressure to the esophagus. So what do you think? Esophagus is getting rid of the size. What is happening to the size of esophagus? When the balloon is inflated, when you are inflating the balloon at this part, what will happen? It is putting the pressure to the
gets
esophagus.
narrowed.
It will get narrowed. How will your swallowing be when it is narrow? It is easy or difficult? Difficult. So it is difficult to swallow. If the patient is eating, during the swallowing, what I can suggest to the patient? Deflate the balloon. These are the two things for the swallowing and for speaking. These are the two situations when we deflate the balloon. Otherwise, we always keep it inflated. Got it? Now, to make it better understanding, I will show you the video right now, and please pay attention, students, here. Okay? Okay.
Welcome to the University of Washington Tracheotomy Care Training after a tracheotomy. We'll start with some basic definitions. A tracheotomy is
okay.
The normal upper airway starts at the nose and the mouth. It connects in the back of the throat and goes down to the larynx or voice box. Below the larynx, air passes to the trachea and to the lungs. A tracheotomy is typically placed about an inch below the larynx. A tracheotomy appliance, commonly called a trach tube, is placed through the hole, and a cuff or balloon at the lower end of the trach tube may be inflated to seal the airway around the trach tube and force air to go into the lungs when the trach tube is hooked up to a ventilator. When the cuff is not inflated, air may pass around the trach tube and may even pass to the upper airway and out the mouth. This can allow a patient to speak when a trach tube is in place, as long as there is enough space around the trach tube and in the upper airway for air to pass. There are several reasons for performing a tracheotomy. Sometimes tracheotomies are performed for more than one reason at a time. The most common reason is to allow for long-term ventilation. This is usually in the setting of a critically ill patient in the intensive care unit who requires mechanical ventilation from a ventilator for a long period of time. The purpose of this is to avoid the discomfort and potential for injury associated with a tube that crosses the larynx and rests against these tissues for a long period of time. Another advantage is that it decreases the distance air needs to travel from the outside world into the lungs, which can help weak patients breathe more easily and possibly come off the ventilator more easily. While the ICU is the most common setting for long-term ventilation, it is also seen in patients with chronic neuromuscular disorders like muscular dystrophy and spinal cord injury. In these cases, the cuff may be left deflated to allow the patient to more easily speak or swallow if they are otherwise able. Upper airway obstruction is another common indication. In this instance, the tracheotomy is done to bypass the obstruction that may be preventing adequate air from reaching the lungs. Causes of obstruction that are seen most often include large tumors, severe scarring, or bilateral vocal fold immobility. Additionally, patients with severe obstructive sleep apnea may be treated with a tracheotomy. Finally, a tracheotomy may be performed for pulmonary hygiene. Specifically, it can provide access to suction or for performing bronchoscopy more frequently and more comfortably in patients with swallowing problems, excess lung mucus, or who don't have enough strength in their chest muscles to easily cough up the secretions in their lungs. This most commonly occurs with a chronic illness that involves the muscular or nervous systems. A number of changes occur after a tracheotomy, so like most new things, it can take time to get used to having a trach in place. The first change is that air bypasses the nose. Ordinarily, a function of the nose is to warm and humidify air as it passes to the lungs. Because this function is lost, there is a need for alternate means of humidification to avoid dryness, which can lead to discomfort and buildup of dry secretions in the lungs. The most common source of humidification is a humidification machine. However, there are other alternatives available, including a filter that can be placed on the trach tube. Also, as a result of air bypassing the nose, smell and taste are often impaired, and patients often experience a runny nose since nasal mucus is no longer easily drawn into the throat as it was before. A tracheotomy may also impair swallowing, although typically not severely. It can impair swallowing by preventing the larynx from rising during the swallow. The second way it affects swallowing is by changing the pressure inside and outside the throat. It can also put pressure on the esophagus and make it difficult for food to pass through, usually more significantly if the cuff is inflated. Voice can be affected by a tracheotomy. When a cuff is inflated, the patient will be unable to talk because no air passes through the larynx or voice box. If the cuff is deflated, a patient can often talk as they breathe out, but this depends on how much space there is around the trach tube. This is discussed.
Okay, students, do you have any question? Did you understand fully about the tracheostomy, about the swallowing, about the deflation, inflation, why food is not going inside, when is the right time to inflate the balloon, deflate the balloon? I hope this will answer your doubts. Okay. Now, yes.
How we can deflate the balloon?
We always just, have you seen the urinary catheter?
Yes.
It is the same. There is a same port. We will inject the air inside it. In the urinary catheter, we inflate with water. Yeah, so it is the same. Okay.
Thank you.
Yeah, you're welcome.
I have seen a patient who is having like tracheostomy, but then he put his finger in the front and then he is able to speak. So how is that?
Because what happened is with the tracheostomy, what happened is when he will put the finger, now when he's talking, where is the air going? He's going through it is going through the upper airway, upper mouth, through his nose, and the air is reaching to his larynx and it is vibrating the larynx. Every time when the patient wants to talk, once again, you can only talk if your larynx will vibrate. Got it? So once you will close your this thing and it is deflated, the balloon is deflated, you will be able to talk. Understood? Are you able to visualize that? Okay. Anybody else? I think somebody else.
Yes.
Janet.
Yeah. Please, what is the accurate air that you have to push to inflate?
It depends on, for example, in the children, it is only 2 ml. Okay, it depends on the size. It is written over there in the balloon that with what size, maybe 3 ml, 5 ml air, whatever the size, it is written over the in the tracheostomy set. It depends with the size. Okay, that how much to inflate or deflate.
Okay.
Okay. Okay, students. So now let's talk about the tracheostomy care. And another very important video is coming through. What important questions which is coming for tracheostomy, I will be sharing you in few seconds. So what happened is when you are, this is the cuff, this is the one. You are Dilpreet, you are talking about the same thing. You pilot balloon, you are inserting the air into this balloon. Okay, that is one it is. So what happened is we have obturator. So this one is the permanent one, and there is a temporary one, the disposable inner cannula, disposable or it can be reusable. Okay, so what happened is whenever you are doing the tracheostomy care, it is a sterile technique. Do you think the old this gauze piece is a sterile? So for example, you are wearing the sterile gloves and you are touching the old sterile old dressing. Do you think your gloves are sterile?
No.
No, not anymore. So what happens, students? Use the non-sterile glove to remove the old dressing. Then put the sterile gloves on. What are you going to do? Remove the inner cannula. This is the inner cannula, which is inserted. We can insert it into the inner cuff and we are going to take it out. Okay, so this is the one. You are removing it, you are cleaning it, and you are inserting the new inner cannula and put the sterile dressing in. What happens if we are going, for example, if the patient balloon is decuffed, it is not inflated, deflated, he coughed out the tracheostomy, this set, the whole tracheostomy is out. What will you do? You will insert it back. But how will you insert it back? You need the obturator. Obturator means a guiding. This is a machine, not a machine, but this is a kind of a guider. You will insert it into it and you will put it into the patient's tracheostomy and then immediately remove it, because patient can't breathe when your obturator is inside. Okay, another thing, why I'm telling you about the obturator, this word obturator, which is a guider, always make sure you have the obturator beside the bed in case of emergency. Now let's suppose I was your patient and I coughed out and it is on the floor. Will you insert that tracheostomy into my trachea? So what is another important stuff which you have to have at the bedside? Tracheostomy set. But make sure, it is important point, if you want to write it down, make sure you have two sizes of tracheostomy. The size which patient have and one size smaller of that. In case if you will try, for example, I am having 8 number tracheostomy set. I put it over, I coughed and it is on the floor. Try inserting the 8, size 8. If it is not happening, then put the size 7. So you must have 2 tracheostomy sizes, one size smaller and one size of the same size at your bedside. Yes, Shadia.
Hi, please, I wanted to find out, here in Canada, who inserts the tracheostomy?
Who does the tracheostomy?
Yeah, who does it?
RNs.
Oh, okay.
We can do that. We can change it.
Oh, okay. We can change it, but we don't insert from the beginning.
We can for the old ones.
Okay.
We do that. I have the certificate. You have to have the certification. So if you are working in the rehabilitation, if you are a registered nurse, you will get certified. There is a separate certification, and then you will get it. And the RNs can insert it.
Okay.
Okay. The fresh one, doctors do that, or respiratory therapists do that.
Yeah, that's what I wanted to find out.
Then no, not us at all. I'm going to show you the video.
Yeah, but we can only reinsert when it comes out.
We can only insert once it is mature.
Oh, okay.
After 14 days.
Okay.
Okay, yeah. So once again, student tracheostomy care. Another why I put star, because it came in NCLEX exam. tracheostomy care is very simple. Sometimes they give you the question, please put that in the right order. Okay, so once again, first of all, you always gather the supplies, put the patient into the right position, semi-fowler position, unless it is contraindicated. Then wear the mask, goggles, clean gloves. Most students are so confused with the goggles. When to use, when not to use. Anytime you're doing something where you have the secretions, you are playing with the secretions. For example, urinary catheter. For example, NG tube. Because patient can vomit, it can go to your eyes. When you are inserting the urinary catheter, patient can pee, it is, you know, anything can happen. So wear the goggles. You're giving the bath, wear the goggles. Okay, there's a universal precaution. When you're giving the medication, do you need goggles? No. Okay, so those things. Remove this, and then what happened? Auscultate the lungs, suction the secretions, because what happened if I have to suction it before? Whatever the secretions, the old one, let it be. Then remove the soil dressing and remove the clean gloves. Put on the sterile gloves. Then remove the old disposable cannula, which is inner cannula, and replace it with the new one. Clean the surrounding stoma with the sterile water or sterile saline. Dry it, and then you are going to cover it with the sterile dressing. So this is the correct way. Okay. Now let me show you one video, very, very important, students. Please pay attention here, and then we are going for break, okay?
And loss of the airway. So write that down.
Just wait.
The
This one
tracheostomy
is really good.
care. The number one priority for a new tracheostomy. We're talking immediately after surgery, fresh postoperative. We must, key terms here, check the tightness of the ties and use one finger to fit under the ties. This prevents dislodgement and loss of the airway. So write that down. The number one priority for a new tracheostomy, returning from the operating room. Now, the NCLEX focuses on things that will kill the patient and other safety topics primarily. So always focus on things that will kill the patient or cause harm. The worst thing that can happen is accidental dislodgement of this tube, resulting in that loss of airway. Since the new trach placement is very difficult to reinsert because it takes time to heal. So we must check tightness of the ties to prevent that lost airway. That's always the number one priority. So don't let the NCLEX trick you here. Priority is always airway. Not performing mouth care to prevent infection, and not doing a dressing change on this new trach or changing the inner cannula. Many students get this wrong. So please write it down. Checking tightness of the ties means maintaining the airway here. Okay, now what happens if the tracheostomy does get dislodged or pops out? Let's say you're going to check on your patient and you find the trach tube sitting on the bed. Oh, snap! Well, now we have a loss of airway from a closed stoma and the patient's gasping for air. This, my friends, is a medical emergency. So what's your first action? To secure that airway, right? So listen close here. For a mature tracheostomy, 7 days or more, we insert the new tracheostomy tube using a curved hemostat. But technically, we should always have an arbitrator at the bedside used to reinsert. And number 2 is we cover the stoma with a sterile occlusive dressing and ventilate the lungs by using a bag valve mask over the nose and mouth. Now, those 2 steps love to show up on the NCLEX, since this is a life-saving intervention here. Now, let's just say it's a new tracheostomy, less than 7 days. Well, then we only do number 2 here, covering the stoma with that occlusive dressing and then using a bag valve mask to ventilate the nose and mouth, since the trach is not mature enough to be immediately reinserted. Lastly, a little side note for other key points.
Okay, so this is all I wanted to tell you. So do you have any question? I hope you understand. So what is a priority of fresh tracheostomy? What is a priority of fresh tracheostomy?
Airway.
Airway. And how to maintain the airway?
To check
By tightening, by
By
checking the tightness.
yes, the tightening the cuff. So if the trach is out 7 days or more, how can we manage this one?
If it's 7 days or more, then we
reinsert it.
insert and put dressing on it. Then we use embo bag, like bag mask.
7 days or less.
That's for less, yeah.
That is for less. So what you do, dressing and embo bag. Okay. So this is very, very important. I hope you understood about the tracheostomy. Now let's
So I think I misunderstood. So
Yes.
what we do when it's 7 days or more?
So what you do, you try to reinsert it.
Just reinsert it.
We reinsert it. And if it is not reinserting, try one size less. If it is less than 7 days, then cover it and start the embo bag. Okay. So this is what we are going to do. Real life, like 7 days, he said, 14 days, we say that. Okay, 14 days. It is a fresh post-op. You are not going to touch the patient like LP. It is the tracheostomy, which is very fresh. It is not for LPNs. Only RNs can take care of that. If it is old, mature tracheostomy, LPNs can do that. They are very well educated. They did their nursing diploma and they are very well aware how to manage the tracheostomy. So don't let the NCLEX trick you. The tracheostomy, you are ultimately thinking that it is my work. Think that how much days tracheostomy it is. If it is less than 2 weeks, it is your patient. If it is more than that, and if it is a stable, then give it to the LPN. Okay. Some tips for the suctioning. Okay, first of all, very, very important. How often do you think we should suction the patient?
Sorry, can you repeat it?
As
How
needed.
often we should do the suctioning to the patient?
PRN.
It is
As per needed.
very good, as per needed. Because anytime when we come from our home back countries and if we are an ICU nurse, we tend automatically every 2 hours. This is our answer. No, we don't do it in Canada. Even if it is a tracheostomy, we do the suctioning. First of all, we always make sure we try the other things first. We try to do the deep breathing exercises. We turn the patient's size. We encourage the patient to cough. And then we do the suctioning as per needed. So when we are doing the suctioning, if you remember the video, I showed it to you, she was doing the suctioning as well, the first video. So when to apply the suction, when you are inserting and when you are taking it out.
Sorry, can you repeat the question?
When you're taking it out?
When you are doing the suctioning, when will you apply the suction? So applying the suction means you will put your thumb onto the suction. Okay. So when you are inserting it or when you are removing it. So when
we are removing it?
When we are removing it. And how long it should last?
10 seconds.
10 seconds.
10 seconds. So another important thing which might you not have studied before, if the patient is conscious, let him sit, let him have the semi-fowler position. Why? Because in case if he's choking, he's in the good position. If the patient is unconscious, okay, turn the head of the bed, raise the head of the bed, but on the sideline position is the good. In case he chokes, the secretion will be out. Sideline position. Do not suction for more than 10 seconds. And this one is very important. I hope everybody knows that, but still I wanted to tell you, do not apply the suction when you are inserting the catheter. Okay. And tracheal suction catheter should not go deeper. How deep you should be going? Not more than 6 to 12 inches. Okay. Now it is a question challenge. The nurse is reviewing the discharge teaching with the patient, with the parent of pediatric client who has tracheostomy. Which of the following statement by the parent would indicate correct statement? Which means 3 out of 4 are wrong and 1 is correct. Another tip I wanted to tell you, whenever you're doing the question, the students will choose wrong option if they will read all the 4 options as such. What I wanted to tell you is read one option, think about it, and then give me the answer. Let's try. I will immediately change the tracheostomy tube if my child has difficulty breathing. Will you change the tracheostomy when he's having difficulty in breathing, or do what?
No.
Is it correct?
No.
No.
No. No.
I will provide deep suctioning frequently to prevent airway obstruction.
No.
No.
We don't do that. I will remove the humidifier if my child develops more secretions.
No.
No.
No. I will travel with 2 tracheostomy tubes, one the same size and one a size small.
Correct.
Yes.
Yes.
Correct.
Good. Okay, another thing, because we were talking about the oxygen, students. So now I just wanted to tell you the normal things to do, not to do with the oxygen. Favorite question for NCLEX exam. Once again, student, no smoking signs. Okay, oxygen in use signs to alert the person. Make sure you know the fire extinguisher. Oxygen therapy in the hospital or at home. Okay. Educate the client about the fire hazards of smoking. Do not smoke. Okay. Do not smoke. Have the client wear cotton gowns rather than the wool fabric. Have you ever feel the static electricity? Sometimes when we touch each other, whenever we do something, there is a static electricity. Yeah. So why it happens? When you are wearing the synthetic clothes or wool fabric clothes. So make sure you tell the oxygen, the person who is on oxygen, wear the cotton gowns. Okay. Ensure if he's using the electrical devices like razor, hearing aid, radios, they are working well. Make sure they are well grounded. Okay, there is no electric spark. And make sure any flammable material, alcohol, acetone, anything, it's not at the patient. It shouldn't be placed near the patient. Okay, so this is about the tracheostomy, oxygen therapy, oxygen devices. Do you have any question for me? Anyone? Before then we will go for break. Anyone?
Yeah, Prof. I was confused about the less than 7 days and more than 7 days. The tracheostomy. Yeah. What I heard is if it's more than 7 days, we the nurses can replace it, reinsert it. But if it is less than, you cover it with sterile dressing and use the ambu bag, right?
Yes. Yes.
All right. Thank you.
Yes. Good. Anyone else? Okay, guys, I've heard a lot about you guys, that you ask a lot of questions, you participate. Why are you not asking me the question?
We understood.
Because you explained so well.
Oh, okay, thank you. I will take it as a compliment. But any questions so far? So that it is because another thing I wanted to tell you and warn you at the same time, respiratory system is very important. Okay, because what happened is over the period of time, we tend to forget what we studied at first. Make the notes. Notes mean only the headings, and test yourself after today's lecture. What I remember about tracheostomy, what I remember about non-breather mask, and that's all. And try to revise it. As soon as, please don't forget things, like try to make sure that I will have 6 lectures of respiratory system. It is very vast. Okay, so make sure you are going to have the notes only on 6 pages. Okay, that is what I want. And now let's go for 15 minutes break. It is 5:50 already. So in Alberta, it is 5:50. So let's meet at around 6:05. Okay, after 15 minutes. All right, I will see you all, students. Now let's get back. Okay, now let's discuss another type, cancer of larynx. Okay, the reason why I am talking about larynx is the tracheostomy only, because it is linked with the tracheostomy, but it is a different kind of tracheostomy. Okay, so that is the reason. So first of all, what is larynx? Larynx is also known as
Voice box.
Voice box.
Okay, so whenever there is any problem in the larynx, so what is expected sign and symptoms?
Hoarseness of voice.
Hoarseness of the voice.
Now, the risk factor of larynx, it is the only type of cancer where we know the risk factor. Only type of cancer in the whole body. Okay, larynx cancer only happen to the people who do smoke or tobacco usage or alcohol intake. These are the only two risk factors, but cancer can happen to any part of your body anytime with the heredity or anything. This cancer is happening because of your, like your habits, alcohol and smoking. Now let's talk about the larynx, the tracheostomy, what we are having. Normally, if you can see in this picture, students, there is a larynx here. When you are breathing in, when you are breathing out, this is a blue is the pathway of your breath. Okay, what is happening? Larynx get vibrated and you can speak. Same thing with the tracheostomy. We are not touching this larynx. Okay, we are not touching this larynx. So that is why when the person will put a finger on his trachea, the air will start going to your nose or your mouth. It will start vibrating and he will start talking. This is what we have studied until now. Now what happened is, this is known as tracheostomy. There is another surgery, we call it as laryngectomy. Removal of larynx. But what happens is, when we remove this part of your body, okay, we will attach it with your neck. This part will be attached with your neck. Can you see that? Now, tell me, is there any pathway that the patient is breathing out or breathing in through their nose? Is there anything?
No.
No. There is absolutely no link of your nose and mouth in the tracheostomy. You still can breathe in and out through your mouth and nose, and your larynx can be vibrated. But here there is absolutely no connection. Now, when they are doing the surgery, students, so another thing which we have to imagine whenever you see the question. So of course, they are attaching these two parts together. So there will be sutures here. Agree? There will be sutures here. Neck flap, we call it as.
Can you repeat it?
Sorry, what?
Can you repeat it?
We call it as neck flap. Neck.
I don't understand where you said that we attach these parts before this.
Oh, attach this part. So let me show you. Just give me a second. So what happened is, when you just try to see this this option number, this figure number 2. So what happened is, when the doctor is removing this part, he is attaching your skin over here. Okay. So what is happening? Is the air going up? No. You can see here, Navdeep. There is no airway going in or going out. So there is no way. So can he speak? No, he can never ever speak. Another important thing, interesting thing is with the laryngectomy. Laryngectomy, because there is a sutures over here. Okay, so what happened is after the laryngectomy, do you think the patient will be able to swallow? Like, is it good for him to swallow the food?
No.
No. Okay, so that is the reason that for that reason, after the laryngectomy, we will insert the NG tube. We will insert the NG tube for 7 to 10 days. Okay, we will insert the NG tube. It is not necessary in tracheostomy. Sometimes we do, sometimes we don't. It is the surgery of your neck. Okay, but in here we do need. So that is why when we are doing the post-operative care, it is a little bit different. Okay, little bit different, and the same thing, the surgery is the same whenever we are doing the surgery of anything of our neck. Make sure you are paying attention to your airway, breathing and circulation. There is a swelling, there will be pain, you know, the patient's eating will be, the swallowing will be affected. So keep those things in mind. I just wanted to tell you the difference between laryngectomy and tracheostomy is this one. He is unable to speak. So once again, I will show you here. Tracheostomy, it is a hole created in the trachea. In laryngectomy, it is a removal of larynx with the redirection of trachea. Tracheostomy is going to happen with laryngectomy, unfortunately. We are using it to treat the airway obstruction, but patient can breathe via nose and mouth. It is only for the cancer of larynx. Patient now breathe through stoma. He can't use his nose and mouth. I hope it is clear with the picture. Speech through the speaking valve, normal sounding, no changes in the voice because larynx you still have. Speech can never be normal again. Can never be. But if we have electrolarynx, there are many things available, TEP devices, we call it as tracheoesophageal pharynx, we call it as, and there is a kind of mic. They are putting it, they are making, creating a sound. They are trying, but it is always, have you heard about Steve Hawkins? Right, the scientist who recently died, but he was
Yes, the greatest physician, physicist.
yes. So he was using that he had the laryngectomy, he has not his own voice, he was talking through the robot. So that kind of robotic voice you will get with laryngectomy. Okay, so tracheostomy, it can be temporary, but once you have laryngectomy, it is permanent and irreversible. That is the thing with laryngectomy. Okay, so this one is about the laryngectomy, airflow. This is this is larynx. There is absolutely no connection with the ear and mouth. Now let's discuss about the post-operative care, about these surgeries. Whenever you have any surgery through your tonsillectomy, if you have tracheostomy, laryngectomy, if you have any kind of like motor vehicle accident and there is a plastic surgery or so, okay, whenever you have head and neck surgery, make sure airway maintenance is your priority. Take care of the wound, flap, reconstruction. If it is a plastic surgery, take care of that. Look for the hemorrhage, look for the wound. Is it infected or not? Pain is there. Nutrition is important because patient swallowing is affected. And laryngectomy specific for all the laryngectomy, not for the tracheostomy. We always give them the referral to SLP, speech and language rehabilitation. We give them the referral to the speech language therapist because it is a biggest change. They can't speak anymore. Okay. What else? After every surgery, monitor the vital signs, check your fluid balance, oxygenation, intake output of the patient, about the wound, how much he's bleeding, what kind of secretions it's coming out of wound. Neck flap viability, that is the neck flap is like what happened to the sutures. So for example, let's imagine there is a plastic surgery, there is a bypass graft, there is any kind of thing has happened. So there is a sutures over here. Blood supply is going to the sutures as well, right? So what happen is, if my blood pressure is very high, what can happen to the sutures? My blood pressure is too much.
Can open?
It can open. Is it good for you? No. What will happen if your BP is low? Your blood pressure is so low that it is poorly going to the suture area. What can happen?
Impaired healing?
Impaired bleeding, not impaired bleeding, it means that it can die. The tissue started getting die. So maintaining your blood pressure after any plastic surgery, especially with the grafting, it is very, very important. Suture line, care to make sure, because he's having the sutures 3 times a day, NG tube should be provided to them. As start the feeding either with the oral after the tracheostomy or laryngectomy with your NG tube. Make sure the bowel sounds are always present and give them the food. They start with the liquid ones. How to maintain the airway? When I say the airway is important, monitor it. Check the respiratory rate, lung sound, auscultate, SpO2. Excessive or retained respiratory secretions can impair the gas exchange, right? So suction it. And whenever you are suctioning it, deep breathing is very good. Coughing is very good. Only after coughing, you do the suctioning. Okay. Airway care, just give me a second. Upright position, the best position for any lung disease is sitting upright. Upright, semi-fowler, fowler position is good. It helps to ventilate the lungs, reduce the edema and swelling. Do the tracheostomy care. Tracheostomy care, we have learned about the cleaning, pulmonary hygiene, suctioning, we have studied already. Okay, so suctioning is traumatic, so make sure that you try the other thing. Whenever you are doing the suctioning, maybe you always do it gently. Okay. And whenever there is a tracheostomy, either it is laryngectomy or tracheostomy, sterile gauze you should be using. We have studied how to change the gauze pieces, how to do the dressing. Make sure you check the cuff pressure. It is not coming out. Patient is coughing. The cuff can, the tracheostomy cuff can come out. Make sure you are giving all the medication the doctor have suggested, when like bronchodilators, antibiotics, whatever, give them. Physiotherapy, humidified oxygen is very much required. Whenever the patient have the bowel sound, start the feeding. And with the laryngectomy, usually we give the NG tube is inserted 7 to 10 days. Usually more days when you have the radiations, because it happens after the cancer. Okay, and make sure bowel sounds are present when you start the whenever you start the feeding. Another thing, student, I wanted to tell you is, for example, you have the sutures at this place, or you had the tonsillectomy, you have the sutures here, or you have the bowel resection surgery, you have the sutures over here. In these surgeries, whenever there is an NG tube placement, okay, there is an NG tube. Do you think the NG, can you see the NG tube is directly touching the sutures? Can you see?
Yes.
Right? It is directly touching. So either it is tonsillectomy, this is laryngectomy, or gastric resection surgery. When you think the tube is directly touching the sutures, do you think it can harm the sutures? It can make it open. So never manipulate NG tube. You can remove it, you can reinsert it to every single person. But whenever there is any kind of surgery where your NG tube is touching the sutures, in GI system, I'm going to teach you the gastric resection surgery, right? We will be learning When the patient, what happened is NG tube is blocked, what are you going to do? Normally, whenever it is blocked, you are going to remove it and reinsert it. But never manipulate it. When it is touching the suture, only doctors can do that. Okay. Okay, advance the oral diet, start with the liquids and then soft diet and then give the other things, solid things. Okay, now let's talk about the ventilators. There is only one or two couple of questions it is coming to the ventilator. So first of all, everybody is clear what is ventilator? It is a pressure device. We are inserting the pressure into the patient. We are giving the breath, deliberately breath and taking it out. Ventilators, usually there are two types of question it is coming. What will the nurse will do if there is a high pressure alarm? What the nurse will do if there is a low pressure alarm? So first of all, you should know what high pressure alarm and low pressure alarm means. High pressure is meaning that ventilator is talking to you, that I am putting too much pressure when I'm giving the breath to the patient. High pressure means I am giving too much pressure. You set me at 20 of pressure, 20 mmHg, but I am taking 40 mmHg to give the pressure to give the breath to the patient. It is talking to you. So what do you think? Why he's putting too much pressure? What could be the reason of high pressure alarm? What do you guys think?
Kink in the tube.
Kink in the tube, Mandeep, very good. Whenever there is a kink in the tube, it is going to give you the high pressure alarm. What are you going to do, Mandeep? To remove
we'll fix the kink.
Unkink it. It's not a rocket science. Unkink it. What else can be the other factors? Kinking is one.
Secretions in the tube.
Very good, Amaninder. So let's suppose I'm your patient. I have too much secretions. Okay, I have too much secretions. And of course, it is ventilator will have to work too hard to give the breath to me, right? So what will you do, Amaninder?
I will suction it.
You will, first of all, you will try to do the deep breathing exercises, cuffing the patient, turn the patient, and then suction. Yes, very good.
Okay.
Okay, very good. Low pressure alarm means ventilator is telling you, I am giving too less pressure. It is easily going. What could be the reason?
Mechanical error.
Sorry, what, Tarpan?
Either it is mechanical error or like a disconnection in the tubing.
Disconnection, very good. Mechanical error or it is a disconnection. So what will you do? You will connect it back. Okay, so these are the two things. So first of all, low pressure and high pressure, don't put too much pressure on your brain. It is very simple thing, as the name indicates. High pressure mainly due to obstruction. Okay, kink, unkink the tube. The reason of low pressure, disconnection. And what you do? You will connect it back. For unkinking, you will kink it, or you will unkink the tube. Sometimes there is secretion, sometimes there is a water in the tube. What will you do? Empty it. Mechanical, yes, as Arpan have said, that there could be a mechanical issue. Sometimes oxygen sensor tubing, you will take it out and plug it in. It will be good. And another thing is mucus secretion, where you will do the suctioning, etc. Okay, so this is the only type of question which is coming in ventilators. So what will you do? Once again, high pressure goes up. What do you do first? Unkink the tube, empty the water, turn the patient cuffing, and then in last you do suction. But before you click on unkink, empty the water, turning and suctioning, don't forget, always assess the patient first and then the equipment. Okay. So for example, if the vendor in the exam, if you have the ventilator question and it is alarming, first you see, is the patient okay? Is Alveen is okay? For example, it is having high pressure alarm, but I'm dead. I'm not breathing in at all. Okay. Or something is choking on me. You see me first and then solve the equipment problem. Any question on ventilator, students? Anyone? Okay. Now let's discuss just a random stuff, diagnostic procedure. So auscultation, everybody know how to do the auscultation. Can you tell me some of the tests we do for the respiratory system? Normal tests we do.
Chest X-ray.
Chest X-rays, very good.
Bronchoscopy.
Bronchoscopy, very good. Anything else?
Pulse oximeter.
Very good. Pulse oximeter, the basic one. Pulse oximeter.
Pulmonary function test.
PF, pulmonary function test. Yes.
Thoracentesis.
Thoracentesis, very good.
ECG.
It is for lungs or heart?
Okay.
Okay.
Physiotherapy.
Physiotherapy we are going to do, yes.
Bronchoscopy.
Bronchoscopy, yes, we do that. So let's study the basic things first. Sputum culture is one of them, right? These are the some pulse oximetry. The first thing we'd always do pulse oximetry. What is a normal range? As you can see, normal range is
95 to 100%.
And what is a normal range of COPD patient? I hope you still remember it.
85.
88 to 92.
80 to 90.
88 to 90.
Yes, 88 to 92%. And make sure sometimes, so pulse oximetry, make sure when sometimes, please assess the patient. So for example, I am talking to you, but my pulse oximetry is telling you only 40%. Is it like me, I am teaching to you and my pulse oximeter is 40. Does it connect with each other? That Alveen is very active. She is all level of consciousness is absolutely fine. Is it a correct reading? No. So make sure that you check the patients as well. Machines can lie, right? So sometimes nail polish, artificial nails, sometimes when it is a cold environment, right? When your vasoconstriction is happening, it can be a false negative report. So make sure that you are going to rule out those things. Another one I've heard is pulmonary function test. Pulmonary function test, as the name indicates. Pulmonary means? Pulmonary system means?
Related to lungs.
Related to lungs. Function means? Function of?
Lungs.
Lungs. Very good. So what is the function of lungs?
Gas exchange.
Breathing in, gas exchange,
breathing
breathing
out.
out, breathing in, breathing out. So any guesses how we do the pulmonary function tests?
Spirometer kind of sort of thing.
Yes, it is a kind of spirometer. Yes, Jessie. So what is happening? We are assessing the lung function. We are checking the function of the pulmonary system. So it is a kind of, so what kind of test it is? We are checking how much Alveen has inhaled, how much amount of air Alveen is exhaling. You need to know the amount of air. Okay, so for example, in asthma and COPD patient, you are doing the pulmonary function tests, right? So for example, in COPD, when they're breathing in, they are breathing, normally what happens is I'm breathing in 1000 ml, like 2 liter or 3 liter of air. And when I'm breathing out, it is 2 liter or 3 liter of air. In COPD asthma, I am breathing in maybe 1.5 liter. I'm breathing out only 500 ml. That is telling you that there is a severe problem in Alveen's lung. It is telling you how much it is reduced. Okay, pulmonary function test. It is a kind of spirometry. What happens is we will close the nostrils and we will tell the patient to breathe in and breathe out through this machine. And we are checking the amount of air. Another one everybody has discussed, like told me already, bronchoscopy. Now the important part for this one is preoperative care and postoperative care. So when I say scopy,
unknown caller.
So what does it mean? Scopy means you are inserting a scope. camera. Okay, for example, colonoscopy, endoscopy, bronchoscopy. So it depends where you are inserting the camera. Another very important tip, students, whenever you are inserting any unnatural thing, the plastic things or any kind, ET tube, endotracheal tube, bronchoscopy, colonoscopy, endoscopy, whatever you are doing it, what happen is we are humans, we are not God. There is a chance when you are inserting, you can puncture that organ. Okay. So whenever you are doing any question with the scopes or anyone, whenever you are inserting any normal thing, you can puncture the organ. And puncturing of the lungs, what we call it as?
Pneumothorax.
Live-in caregiver. Very good. Pneumothorax. Okay, students, one request to each of you. I enjoy when you talk to me, but we get equally disturbed when you talk to your family members. Okay, make sure you are muting yourself before you answer the family members. Okay, pneumothorax. So puncturing of the lungs, what happens is it can lead to the pneumothorax. So same time, what is a complication of like ETT tube, endotracheal tube? What can happen? You can puncture pneumothorax. So for example, you are doing the thoracentesis to the lungs. Is there any risk of puncture? Yes. So what will be what is the complication? Pneumothorax.
What about hemothorax?
Hemothorax can happen as well. Pneumothorax can happen as well. Right? So what happens is pneumo means air. Hemo means blood. Empyema means pus into the thorax. Empyema will not happen, but as soon as you will puncture it, the air from the outside world is going to enter. It can cause the tension pneumothorax. The air will enter where? Not in lungs. Lungs are full of air. Tell me where the lungs, where the air will enter.
Blood.
Huh?
Pleural cavity.
Pleural
lung spaces.
Here. So what is happening when you are inserting this one? You can puncture the lung and your lungs can be all shrinked like blue, and there is all air in the pleural cavity. So what will happen? Will you auscultate the lungs here? So lung is collapsed. Collapse of lung can happen. Will you auscultate here? Anything? Can you auscultate air? What is auscultation? Breathing in, breathing out. Can you hear that sound here?
No.
Can you sound here? No. So what will be the sign or symptom? Absent breath sounds. Pneumothorax. We will study about pneumothorax. I don't want to teach you pneumothorax at this point. Let's come back to bronchoscopy. So tube is inserted to see that, to visualize the airway. And you just imagine yourself. So for example, you're having the glass of water and you just have, you choked on a couple of drops of water. What will you do? You are started coughing, right? With the bronchoscopy, do you think you can handle the big tube into your airway? Can anybody handle? You can't even handle a little drop of water. So what happened is, do you think we need to sedate the patient or no?
Absolutely.
Yes. Absolutely. So whenever we are sedating any patient, do expect we are putting the patient to NPO. For endoscopy, we don't need it. The patient is going to have the gag reflex. It depends. If we are going to sedate him, we are going to tell him for NPO. Thoracentesis. It is a needle to my lungs. Do I need to sedate the patient? No. Will you keep him NPO?
No.
No need. Okay, so make sure. The NPO comes because we need to sedate him. And when we are sedating him, make sure that all your reflexes will go down. All your reflexes. You won't be having the gag reflex, you won't be having anything. So make sure that after the NPO prepare for the sedation, atropine sulfate is to decrease the oral solution, normal medication we are going to give. Make sure that after this bronchoscopy, when you are offering the fluid to the patient, because he's NPO, make sure his gag reflexes return. If it is not, the patient is risk of what? Choking. Okay, so always make sure. And monitor the patient for the complication. Which complication? Pneumothorax. Now another thing, just like I told you, when I say the word chest pain, normally everybody think in one direction, which is MI. Same goes with sore throat. What does the word sore mean? Sore mean pain? Throat means in your throat. Because the problem is when I say the word sore throat, you automatically think about strep throat, bacteria, viral infection. It is not that one. So when I do the procedure, when I have inserted this big pipe into your throat, don't you think you're going to have pain after the surgery?
Yes.
You are going to have. Pain in the throat means sore throat. So don't automatically start thinking sore throat, oh my God, infection, oh my God, bacteria. Sore throat is expected. Dry throat is expected. The patient, we have given atropine. Another thing is because our cartilage is so like it is very soft. Sometimes when we are inserting the big pipes and keeping it up and down. So what can happen? Sometimes a little injury can happen. So if it is bleeding, so there is another problem, students. Blood tinged means like for example, if I'm having the tickle, yeah, so there is a little touch of blood. So for example, if I'm having sputum, so when there is a lot of sputum, the yellowish color, there is a little tinge of blood. Does it mean that I'm bleeding heavily? No. So make sure blood tinged doesn't mean bleeding, he's hemorrhaging. It is expected. And whenever you are inserting, what happens is you are touching the larynx also. Sometimes when it is too long, when you keep on, bothering the larynx too much, larynx gets swollen. Larynx edema can happen. So what will be your sign and symptoms?
Hoarse voice a bit.
Hoarseness of voice. Okay, so once hoarseness of voice, we don't want it, but it is one of the complications. You can tell the doctor, maybe we need to give some anti-inflammatory drugs to this patient. Okay, so always think larynx is just over here. It can happen. Okay. Another is thoracentesis. Thoracentesis, once again, removal of the fluid from the thorax cavity. Thorax is this chest. Do you think, do we need to sedate the patient in this position?
No.
We don't need it. What are we doing? We are inserting the needle. What can be the complication? We can puncture the lung. And what we call it as?
Pneumothorax.
Okay, very good. Thoracentesis. Now, what is very important for thoracentesis is the position, pre-procedure and post-procedure. Pre-procedure position is the most important. So what is the position? What is the best position we are going to give to remove the fluid? You could have seen in the last slide. What was that? Patient must sit upright.
Sit upright.
Arm should be supported on the bedside table. Do we tell him to walk around or something? We have to tell him, don't talk, don't cough, remain still. If he will not remain still, what will happen? Pneumothorax. Not to talk, not to move, not to cough. Okay, so do tell him about these things. Just give me a second. Why this is the best position? Can anybody tell me?
Gravity work itself.
Gravity. Very good, Jessie. So gravity is working. Okay. Now the post procedure. Post position, what is a complication? Pneumothorax. So look for that. Hemorrhage, bleeding can happen. Look for that. What is a sign and symptom of hemorrhage? I'm talking about hemorrhage happening due to this procedure.
Hypertension.
Very good. Bleeding. Can you see the bleeding from your lungs? Actually, no, right?
No.
Unlike if it is not GI that I'm having the vomiting of blood, it is not my GI tract that I'm peeing and I'm, having the bowel movement of blood. It is inside. There will be changes in my vital signs.
Vital signs.
Check that. And how to check the X-rays for the complication if it is suspected. And make sure, because when you are re-expanding the lung, tell your patient to do the lungs exercises, deep breathing exercise to expand the lungs after the procedures. Okay, so these are the things. Now let's do one question, quick question. Nurse is caring for a client receiving mechanical ventilation. Which of the following action by the nurse require follow-up? Follow-up, we are looking for correct statement or incorrect?
Incorrect.
Incorrect.
Very good. Incorrect. Administer morphine to the client to relieve the anxiety and restless for the mechanical ventilations. You can have a guess. I wanted to share this question because I wanted to discuss these steps as well. So what happens is when the ventilator is there into our throat, is it comfortable feeling? Do you want the patient to be alert with the ventilator? He will be so anxious. He will be so restless. You cannot have anything, any pipe into your throat. So how we do that? Usually we do give some kind of sedations to them.
Sure.
You apply the suction when inserting the catheter into the airway.
That is the correct option.
That's the best.
Wrong.
Yeah.
Always increase the oxygen concentration on mechanical ventilator before suctioning.
Yes.
Very good. Yes. The reason is when you are suctioning, what does suction do? Remove the secretions, right? Is it removing only the secretions? Actually, no, it is removing the air also, right? So make sure that you hyperventilate the patient. You give the oxygen, pre-oxygenate the patient before and after the suctioning. 10 seconds and immediately give the oxygen to the patient. Suction when mechanical ventilator high pressure alarm is continuous to sounds and rhonchi are present. Rhonchi in the bronchi. Do we suction or no?
Yes.
Yes, we do suctions, right? So what is the incorrect option? Option number 2.
So meanwhile, it is the correct option for this question.
Sorry?
So it's correct option for this question.
No.
Second one.
No. It is wrong. Why it is wrong? You tell me.
But we need to identify the incorrect option.
Yes.
Avleen,
For giving
Avleen,
the
I think
correct answer.
she's trying to say that second is the right answer.
Yeah, second
according
is
to
the
the
right
question.
option. Yes. Second is the right option. This crosses mean I'm going to choose this one. Okay. So this is the one. All right. So tomorrow we will be discussing about the respiratory medications. So students, what we have learned today. So we did discuss about today's respiratory 1 class. So what did we discuss today? So
Assessment.
we discussed about the assessment. Okay. assessment. We did about the inspection with an eye. You don't need to anything. You need not to note anything. Maybe what is new to you? Maybe barrel shape. Okay, barrel shape was to the lungs. Then we auscultate. Auscultation, crackles. Crackles happens only in the with the any disease with fluid. Okay. We studied about wheezing. It sounds like whistle, right? I'm trying to type with my mouse, so please, I am not, my handwriting is not that bad, but it appears so super bad right here. So strider, like a squeaky door. Squeaky door. And it is very urgent, right? This is what we have studied. Right? What else? Assessment we have done. Then tactile firmitus we studied about the vibration. Right? Then what else we studied? We studied about
respiratory support system.
The respiratory support system. You don't need to talk about nasal cannula, etc., because you already knows about that. Maybe you want to write about non-rebreather mask. Right? How to inflate. How to inflate. How to inflate, students?
Increase the oxygen pressure on
to the highest. Very good.
Highest.
To the highest non-rebreather mask. Then we studied about the oxygenation is different, perfusion is different, ventilation is different, right? What else? We studied about the tracheostomy. We studied about the fresh post-op. We studied about 7 days plus fresh and mature, right? Fresh, what we are going to do, cover it
and
plus empty bag. Mature,
reinsert.
Reinsert. Make sure you are having the same size
and small.
And the size smaller than
a small size. Or what else you should be having at the bedside?
Matured is more than 7 days, right?
Empty bag should be there. Suction machine should be there. Right? You should be having these things. Then we studied about endotracheal tube. Endotracheal tube, everything is good. Just make sure X-ray is important. Okay. For this one, infection can happen. For suctioning, you don't have to write every single thing. Suctioning. Okay. Suctioning, 10 seconds. 6 to 12 inches deep. Okay. And then only apply while removing it. Remove, apply the pressure, apply the suction, apply the suction. Okay.
And clink.
And what else?
Positioning.
Positioning, right? Positioning, if the patient is conscious, then semi-Fowler position, semi-Fowler position. If it is unconscious, then sideline.
And sound, mention ventilator, a ventilator sound.
Sorry, what?
Ventilator sound.
Ventilator, we studied about ventilator, high pressure alarm, low pressure alarm, right? When there is a blockage, and when it is when the system is all out. Okay.
Defaulted.
Yes. And then ventilator, we studied about what else? Yeah. And then we have a pulmonary function test, is a kind of spirometer test. Okay. We studied about spirometry. We studied about pulse oximeter. You don't have to write anything. Spirometry, you already know. Be very concise with your note. Only write it down, which you can forget.
Do we have to remember the percentage, like the FiO2, the colors and the
No,
ventures and all that?
FiO2 you don't need to, because it depends on the question. You don't remember, they will tell you the FiO2 is this one. You don't have to remember anything. No need to remember about the person. Even in the real world, even until now, I always check the color of the venturi mask, right? I always, because it is written, the doctor said 50% or something, I always go and read it. It is very handy. You don't have to remember those things, no.
And in case the suction is asked, so which one will be done first? Is it the nasal one or the oral suction?
Yeah, so it depends. So it depends on the situation. So for example, if there is a child whose nose is blocked, we are don't using the nasal if it is not being used. If there is a choking, we use the suctioning, or always oral first. Okay, and if there is a tracheostomy, you do the tracheostomy. It depends on the situation, what the question is telling you. Patient is choking, oral secretions. If the patient is having tracheostomy, do the tracheostomy secretions. Okay, so that is one. In real life, if the patient is having the tracheostomy, if you are an LPN, right? So we always go with the tracheostomy, sterile, clean to the dirty area, not dirty to the clean area. Tracheostomy is the sterile. We always do the sterile one first and then go and clean the mouth. Okay, and then PFT, we studied about the thoracentesis. Just write down the positioning pre and post-op, right? Some of the things. So bronchoscopy, then bronchoscopy, you are going to do the pre and post-op. These are the little things in one paper. If we are forgetting anything, you are going to, after this today's lecture, you are going to revise it in my lectures, in my presentation tab. Quickly go through. It will take only 15 minutes. Anything you are missing, you probably are going to miss forever. Okay, so write it down with a separate pen. Okay, for example, here, oh, I forgot about pneumothorax.
Laryngectomy.
Laryngectomy, right? So write it down, laryngectomy. Yes, I can forget. And there is 7 to 10 days and like NG tube we are putting for after laryngectomy, right? Larynx, when we are going to remove the laryngectomy. So these are the little things, how to make the notes. And it should be done only on one sheet method. Okay, and it is so easy for you to revise. Okay, yeah. So now let's ask the question. Students, do you have any question for me today?
Yes, ma'am. Actually, in thoracentesis test, can we give a local anesthesia?
Yeah, it depends. Yeah, we can give the local anesthesia. We usually give anytime we are inserting, for example, during the maternity, right? When you are going to have the, like the spinal infusion, then they usually give the local anesthesia all the time.
For any invasive procedure.
For any invasive procedure, yes.
And while doing the tracheostomy suctioning, is it like intermittent suction or is it just a continuous?
You tell me for that one. You give me the answer.
I believe it should be continuous.
Continuous, what do you mean? Like continuously?
Once you, no, once you're bringing the catheter out, so you apply the suction, right? So I mean, like you keep your thumb on it for
10
like
seconds.
whatever. Yeah. So it's not like you do it like this in intermittent, like, okay.
Oh, no, we are doing the 10 seconds and we are rotating and we are removing it.
Okay.
Yes.
Yeah.
Anything, anybody else?
Lena, I have a question related to larynx. It's not related to the topic we did today, but just for curiosity. very rarely encounter people sometimes with horsey voice, a bit of harsh, and they have a paralyzed partial larynx, and then people go for surgery to fix that. So what do they do in that case? So they try to bring the paralyzed part close to the other vocal part, or do they like how does that happen?
So maybe when you are paralyzed mean your muscles are not working, right? So it is flaccid. It is not, for example, my hand, it is active. I can do the things. But when it is paralyzed, I'm all gone, right? So what happened with the larynx? It is standing straight. It is standing straight, and what happen is when it is paralyzed, it tends to move here and there, left or right side. It can affect, first of all, if it is going to your endotracheal tube, it is going to affect the swallowing issues. There is a kind of blockage. So that is the surgery when the doctor is trying to manipulate it to make it stand, so that we are not doing anything, we are not attaching and removing it. Its only job is to vibrate.
Okay, so they insert something in it? Like, how do they make it stand if it's floppy?
I'm not sure about that. I've never read about that. I would ask my doctors about that. But because it is very little, there could be a chances, but I would love to find out for that. Because I never asked this question, but this is very interesting question. I would love to ask my doctor about that.
I was just curious too, because I never understand the concept, like what do they exactly do? Because it's supposed to move with vibration. And if right, and after surgery, what if they insert something, then it's fixed? Then how does the voice come? So it's just never got clear, and I'm always curious, how does that work?
Yeah, no, I will ask the question, but the main focus is not to removing it. Make sure that it is standing so that it is vibrating. It is not doing its job. It is our breath which is doing its job. Right. We are just making it little bit standing so that it is in working condition, so that whenever I am breathing out, it is in touch of my breath, so that it is vibrating. So that is the major goal. How they do it, I would love to know. I will ask some of the surgeons.
Thank you.
Yeah, definitely. Where do you work, Jessie?
I work in a public health right now, but I work many places. I came to Canada in 2008, and I started in a children's hospital, working a merge on float pool, then nursery, then high risk labor floor. Then I switched to orthopedic neurosurgery, then I switched to plastic surgery, then day surgery. And then I had kids, so I moved to public health because I couldn't commit to 12-hour shift. But I was working as a nursing assistant.
Okay, that is nice. You're working as a nursing assistant. You have a good knowledge, yes. So any student who is working as a nursing assistant, who is working as a registered nurse, not registered, licensed practical nurse, right, or RPN, please make sure from today's onward, whatever you see the patients, try to see the pathophysiology, why he's wheezing, why he's doing this thing. Cardiology is very interesting. You will love cardiology, why he's having this murmur, right? We are going to learn everything. So the more whys, the more hows you ask, the better it is for your NCLEX exam. NCLEX will ask you. If you won't ask me, NCLEX will ask you in the exam. They will not ask you what is a ventilator. They will not ask you what is a definition of high PEEP, CPAP, BiPAP. Not interested at all. They will ask you the question what you are not asking me. Better, the more question you ask me, the better it is for you.
I was actually nervous joining this course because I feel like everybody's more intelligent than me and they know much more, because I graduated from nursing back in 2007 and I have a 16-year, almost 18-year of gap. So I am very much nervous regarding my journey towards RN, because now that the kids are old enough, and I thought, okay, this is the time to go back to school. I can afford to study, and so I'm on education leave for a couple months. That's why I'm taking this course.
That is good.
Right.
I'm so excited. Yeah, but don't take that one as a, like you don't take it as an excuse, Jessie. Okay, so what happened is I have the students who passed out 25 years ago. Who are like my mom's age, to be honest. They are born in 1960s or 70s sometimes. I have those students. And sometimes I have the student who passed last year and who said, ma'am, I have a huge gap. There is 1 year. I said, no, don't do that. Everybody's on same gap, same boat. When you forget after 1 year, everybody forgets it. So the reason why I'm telling you that 30 minutes before you come to the class, it's not necessary that you have to cram the things or you have to understand the thing. That is my responsibility. That is Saran's responsibility. We can explain you in the class, but as soon as you will see the word tracheostomy before coming to the class, so you know what I'm talking about. Oh, okay, I got it. So everybody is on the same bit. We will make sure that we are answering all the fundamentals questions. I'm not going through the whole anatomy, physiology or something, not like that, but I will make sure you know that before we proceed further. I hope that the topics we covered today, tracheostomy is one of the difficult things. I hope I made it clear. Laryngectomy, it is one of the highest, maybe you have never thought about it, that I will study about the laryngectomy, tracheostomy, fresh post-op, but everything made sense today. Okay.
To be honest, the way you explain and we watch the videos, I don't even remember when I was doing my nursing that it was ever explained that good. So many concepts I got clear today. Like
Yeah,
it does make sense. Things start falling in place and be like, okay, that's why I'm keep forgetting that, because this concept wasn't clear.
Yeah, because
so it was
see,
very
the
nice.
chest tube. So for example, chest pain, that is a common thing. To be honest, even I have told you in my today's first lecture, I'm damn sure, please do remember this thing. Chest pain is not always myocardial infarction. It can be GI, it can be your esophagus, it can be your trachea, it can be your lungs. Sore throat, another thing. We are using sore throat as a step throat, right? Whenever you're sick, I'm having sore throat. We are using this term for a long time for the wrong situations. So we tend to focus on sore throat infection, sore throat viral infection. Don't say that. Okay, we are going to cut it. It is very simple. Medical surgical is so interesting. I hope everybody will enjoy it. But ask more and more questions. That's what I wanted to tell you. That is the only mantra I want to give you. Anybody else? And the students who are not turning their cameras on, please turn your cameras on tomorrow.
Hi,
Yes.
Prof.
Yes.
Please, apart from the antibiotics that you use to treat post-op infection and other things, what are some of the medication that helps with the healing and other things?
We will discuss it tomorrow.
Okay.
Yeah, we are going to discuss tomorrow the medications. We will have a separate class. And even my cardiology medication, I will cover it in 2 days. And then we are going to revise it forever. So medication. And another thing is, don't worry about the medication. Pharmacology is something which all the nurses hate. Okay. I just wanted to assure you that whatever the medications I am teaching you, Saurabh is teaching you, are more than enough. There are a couple of medication you need for respiratory system. Cardiology medication is very important. Mental health medication is very important. Majority of the question will be on cardiology and mental health medications. Make the notes, okay? And then rest is steroids, very important, right? Those are the things, beta blockers, etc. We will cover all the medication and whatever, like I think Janet, tomorrow all your questions about the medications will be answered. Okay.
Ma'am, I would like to ask, do we need to remember all the normal lab values for NCLEX or?
Oh, you guys are so lucky, believe me. We had to, but not you guys. Last year when the NCLEX changed, April 2023, when they changed the new generation is like a real time feeling. So in your real world, you have the phones, mobile phones with your normal range. In the real world, every time, every report you get, you have the normal value. Same in the NCLEX exam, they are going to give you the normal values beside it. You don't have to remember. Yeah. And you guys are so lucky, you have SATA question. The passing rate is increased than the last years. Maybe because I was talking to one of the students, they are saying, ma'am, I want to become registered nurse because I have this student, that student. Like she was not as intelligent as me. She passed her NCLEX exam. So I don't want to judge anyone, but this is a good time. Yes, you can pass the NCLEX exam because SATA question, it is specially scored. You have the normal ranges, so it makes your life easier. So yeah, so best of luck, students. You take the advantage of this situation and be serious. It is not as easy. So try to be serious, try to be persistent, try to be proactive, right? As Sarab usually always says this example, always believe in ease, your effort, not the excuses. Because this first week, to be honest, all my students, first week, you are pumped up. You recently started the classes, you want to come to the classes. But what will happen after 1 week or 2 weeks or 3 weeks? Then it is a real test for you, right? Then the students who will be keep coming to the classes, who will keep the same energy level are the winners, will be going to be the winners. I can totally see. Okay, so I keep it up and keep asking the question, keep coming to the classes. And students, please turn your cameras on so that I can see your beautiful faces. Nobody is sleeping or anything. So keep asking the question and showing me your faces. Okay. Yeah, I can see some of you guys are driving, but I'm absolutely fine. Okay. And who is Mr. MR? So make sure whenever you are joining the class, you edit your name. Okay. I hope everybody has given me the attendance. Did anybody give? I can see the attendance as well, but please make sure you have written your name, and that's all. I will see you all tomorrow then. Okay. All right, students, I will give you just a couple of minutes. Please write down your name and I will be taking your attendance.
Ma'am, sorry,
Yes.
I have another question. It just like, so NCLEX, the format of NCLEX exam changed after every 3 years. So is it going to change next year?
It is not going to change every 3 years. They see every 3 years, they will assess that how is the new nurses doing.
They review it.
They review it. And then it depends on them. Okay, because previously what happened, the NCLEX was very difficult because of the range, because of the SATA, and now they have case studies. They are inserting the case studies. They have inserted, so they will review it.
Okay, thank you.
Mamta, make sure you change the name. Whenever you can edit your name. Okay. Okay. All right, student. I will see you all tomorrow then. Okay. Bye-bye.